question is for Dr. Braissant. I saw some of the behavioral data that you just showed on the plasmase and the open field activity as well. I was wondering, just taking a page out of female CTD patients, what do we know about their visual acuities, and do we know anything about visual acuity in rats that might influence the readout on those tests?
You hear me? Yes? Okay. That's a good question. Honestly, I don't have the answer on the visual acuity of the rats. And they are more relying on smell, and so I don't know.
It's a question over there.
Good morning, everybody. So I'm a carrier. I've got 6 sons, and I've got a daughter too. And in France, it's impossible to have a diagnosis before adult age because it's in the law. You can't ask for a diagnosis for your daughter. The law is the daughter will ask for herself at adult age. And for me, I understand it's a pity because there's the question of scholarity, there's the question of behavior, and I'm really wondering if she's a carrier. Do you know if we have an issue to have this diagnosis? Because my daughter is quite anxious about her scholarity and her future possibility to have children herself. Thank you.
Maybe Jiddeke, you want to?
Yeah, this is always a problem. Also in the Netherlands, that genetic testing for carriership, that's usually said that you should do when a child is become an adult and can decide for her or himself whether she wants to know if she is a carrier. But I think it's really a difference in X-linked conditions, as girls can be symptomatic and have already at an earlier age, it can be relevant to know if they're having the mutation. So in the Netherlands, we are not that strict anymore. And we would test if parents want to know, and if there are questions about what that matter for the girl at that time. So if there are questions about schooling or about worries about the development, we would of course discuss that. Also the consequences for a girl. Maybe you can tell more about it. Knowing at an early age that you are a carrier, that's also. If you don't have symptoms, and I don't know how you felt about that. Maybe you can say something about that. Yeah.
Yes, I can definitely add to that. So I think it's definitely a personal experience, but knowing from a young age made my psychological adjustment period so much easier. And I feel very lucky that since my dad had the condition, that we knew 100% that I was a carrier and that we didn't have to go through the unknown. It's the same in the US where there's not a law that prevents it, but there are guidelines. And I think the issue really comes down to the fact that we still use the carrier terminology with X-linked conditions because the guidelines state that there shouldn't be carrier testing. But as you know, so many of us have spoken about that it's a spectrum and we're not really carriers, even if we are on that very mild phenotype. I don't think the term carrier really fits because it puts us in a box and it causes these laws and these guidelines to apply to X-linked conditions when I don't think that they should. But there also has been research that shows that when a condition has a 50% inheritance, that not knowing and having to wait for testing actually causes more stress and more difficulties than just going through the test, and that a lot of people assume that they do have a positive result even before going through testing. So I think there are so many benefits to being able to test at a young age, especially when you have symptoms in childhood.
Maybe if I can comment as a geneticist and working in France. So we have in La Pitié-Salpêtrière Hospital a huge center for pre-symptomatic testing. And there is a huge difference between actually when you have a condition where girls can be affected at the early age, and when you have a disease like, I don't know, mild neuropathy, that will essentially only present as adults. So I'm surprised, but I hear you that this is complicated because we have obviously not that experience. But I think what is important and what we do with genetic counselors on at least France, in all centers, is to educate people. So if there is a barrier, we should address it because there is no reason why in this condition girls
It has
should not
been
be tested.
said at the very appointment when we had the diagnosis for my son, and I found it really violent for me.
Of course. But I think it's important, maybe through the association or something, if there are similar experience, because we did that for other X-linked disorders, to go back to genetic counselors and genetic centers to explain, because that should not be, for sure.
May I add something from the diagnostic laboratory point of view? We do probably several thousand of creatine tests a year. And about 10% are diagnostic because of symptoms. When I went back and looked at my experience in the last few years, I have checked, and if we have an abnormal result that is suggestive of a problem, like in this case could be CTD, we call the physician immediately. In many years, we have called probably, I would say, about 10, made 10 calls for an abnormal result, and out of those 10, 2 were confirmed with creatine transporter deficiency by DNA testing. What does this mean? This means, and when I look at the data also, it means that especially in a female, I think that you have values, biochemical values that are within, they may not be outside what we call the normal range. And sometimes people stop there because the biochemical test is negative, and they shouldn't, because not all the females are going to be identified, while all the males most likely have an abnormal result. But when I look at the data that I have, the values for female with CTD are about 50% the value of the boys. So what does that mean? That depending on the age group and the population that you have used to calculate the reference ranges, this value may not be outside, may not give you an abnormal result. And this is true even with ALD. 20% of female are not identified by biochemical testing. So I think that that's really, that's a problem, because many people stop there and they don't think that they really need to go and do DNA testing.
Thank you. Please go
I
ahead.
still got the mic. Just some feedback from Germany. We've got also quite difficult situation with genetic testing due to our history. But we could convince our doctors. When I was giving birth to our daughter, we have a son with CTD, we argued like we could give her some therapies early and start early to work with her and her maybe special needs. And in this situation, they agreed to do a genetic testing, because we said, we've got that son, and he was 2 when we got the diagnosis. We said, okay, that was pretty late already, which is not, I know, but we want to support her as early as possible, and that worked. Maybe it works for some people here in Europe as well. But when I was raising my finger, I had another question, because I'm a carrier, and I just wondered if there's any experiences with women getting elder, being a carrier, and facing some, some syndromes, let's say. Because I just saw this with your presentation, and sometimes I feel that my short-time memory becomes worse, and I don't know if this comes from the overload that I've got, or being just elder, or if this might be part of CTD as well.
Well, we don't know. So the girls with symptoms, as far as I know, are usually at an early age. Well, there will be a spectrum, of course, again. I know of only a few girls that developed more symptoms in life, but were still at an earlier age, still in childhood. So we don't know, but I think it's something that we might, well, learn more about, and well, so for us it is very good to hear from you and hear your experiences, and maybe we should look into that.
Maybe Audrey can further comment on the questionnaire on the older patients you had.
The questionnaire, we did not ask question about memory, so I cannot.
But overall, on the other things you had, 48 was it? No,
48.
Yeah,
correct.
right. So was the person very different? Do you remember?
She was from the most independent person.
Okay.
There were some difficulties, but mild. It was a milder phenotype. But we had absolutely no information about memory. It was all about development or epilepsy. So.
And maybe, they are just maybe small advice, but you can actually go and have some neurocognitive testing to see where you are, because because they are able to tell a bit if this is related to some exhaustion, some anxiety, or if there is something a bit different. Not saying abnormal, but at least different. And this sometimes can be help, especially with speech therapy, with health, doing some cognitive support. That's help for some things. I mean, but maybe you just don't have it. So if you are wondering, I think I will be seeing you. I will recommend that. Just
a small comment I wanted to add. I think with carriers being females, I think there's also an aspect of gender bias in healthcare. I think something that we see in the ALD community, and sounds like could be similar here, is just with older women who have symptoms, 30s, 40s, 50s. So often doctors might think, oh, it might just be anxiety or being a worried mother or being just a woman. There's this assumption that being a woman means that you are worrying all the time, which obviously a lot of women, especially if you do have a child with a rare disease, women are still most often the caregivers. But I think that's what makes it so complicated, sort of to know, are these symptoms related or are they not? But I think just more research on especially the older population, and so you can at least have an answer, even if there might not be something concrete at the moment to help. I think having an answer, at least knowing, like, is this related to my condition? Because we see that in my community as well, and we've also noticed that when males and females have the same conditions, it is females who get the questions from doctors like, oh, maybe it's anxiety or it's in your head, and males who are experiencing the same exact symptoms don't get asked that. So,
and it's very true, because this is what Olivier emphasized. We don't look at female mice, we don't look at female rats. I mean, now it's actually part of the ethics of doing research that you have to be aware of that. But precisely because of the experience in ALD or adrenomyelopathy, we actually test our women with symptoms, and sometimes it's actually anxiety and needs to be addressed because anxiety is a symptom, or it's actually something else. And then they have support and it's better. Olivier, I had a question for you, if I may. So about your homozygous rats, so they are definitely more symptomatic. For some parts, they look like your males. But there are some aspects that actually look normal, especially some cognitive aspects. So what's the compensation here? What is your hypothesis?
We don't know at all.
Yeah, but can you try?
Well, we would have expected that they were going worse than the heterozygous, and for some aspects they look normal.
Because they have no creatine, right, on your
No,
spectroscopy, right?
No, they are like males. Yeah. I have to search more.
Yes, there is a question. I don't know, where's the microphone? Two questions, actually.
Yeah, I had a question for Audrey about the study she did of the 21 girls. So did you perform some kind of comparison with the symptoms with boys and see if there is or if there are any differences?
No, I'm sorry, we did not do it.
So maybe just in front, just to have the mic move on. Just there was... Yeah.
Yes, thank you. Actually, my question also goes to you. The heterogeneity that you described, that you see in the girls, do you think it could just be explained with X inactivation, the fact that it's random? So meaning, you know, if the girls are so not heterozygous, so heterogenic, you know, some are just more like males and others are not. Is that a way to explain it?
This is just a descriptive study, so we did not try to explain the results, but maybe there's a part of random in it. But I think the symptoms really exist for most of them, because we can see that all of them have symptoms. So maybe there's a part of random, but we did not try to explain why. But parents did notice that their girls had symptoms. So
yeah, we have somebody here who wants to talk to. I also have another question regarding the diagnosis. When you do genetic testing, you do it in peripheral blood cells, right? And the lionization happens, as Jiddeke said, in 6 to 16 cell stage. So to what extent is there a possibility that we actually miss X inactivation in a particular cell? You know, or like to what extent do the blood cells represent all the different mosaic parts?
Well, the DNA you will see from both X chromosomes. So the DNA, so you will see the mutation also when it's on the inactivated X chromosome. So the DNA test is just reliable. But X inactivation. If you look at the X inactivation pattern, there's also something that we can do to see to predict how many cells have the normal copy active and how many cells have the inactive gene active. Well, when you do that in blood, it can be different in other tissues like the brain. So there was actually a very recent paper looking at how much the X inactivation pattern in blood will predict the X inactivation pattern in other tissues like the brain. Well, based on that paper, I would expect to find some correlation between the X inactivation pattern in blood and also in the brain. But it's very difficult, and you have to make calculations based on how many cells are actually going to form the brain cells, and there are quite a few cells forming the brain cells. So, and there are different cell types. Well, different cells as well, with the mutation active or without the mutation active. Well,
was another question still there? No, you haven't. Okay. Yeah.
Thank you. Thank you to all of you for your very interesting talks. Definitely working on females and is interesting and mandatory to all of us. And I have a question to Jiddeke. Do you still recommend supplementation with creatine? And also, what about glycine and arginine in females? Because we know that in males it doesn't work. But what do you recommend in clinical practice for females? And I have also a question to Audrey, but after.
Yes, I think that's difficult because indeed in boys there were more studies, and then we said, well, we see that really an increase in the creatine in the brain, so we're not sure it's doing anything. In girls, we don't have this kind of studies. There are some case reports telling, well, very more enthusiastic stories about girls with epilepsy, and that they had, well, the epilepsy was less when they were treated. But I'm not sure if it's different in girls. As I said, there are cells that are able to uptake creatine, and there are cells that are not able to uptake creatine, and I'm not sure if that's, well, you will be able to treat the cells that are not able to uptake creatine. They will be the same way as in boys, so I'm not sure if there's a difference there.
And for the cells which the good transporter,
yeah.
Is there a risk of negative feedback with a higher amount of substrates, and to have negative feedback with a less functioning transporter? Is it a possibility?
It is, yeah, well, in theory, it is a possibility also that, well, we don't know exactly what happens if you have two different cell types. We think, well, they might just coexist and they might help each other. I don't expect that too much. But they can also be, sometimes in X-linked conditions, even worse to have two different cell types next to each other.
That was my question.
So we don't know. It could theoretically also have another effect. True.
Okay, thank you. And for Audrey, do you know how many girls or women have a diagnosis of autism spectrum disorder? Maybe it's not exhaustive because we didn't ask specifically if there was a diagnosis of autism, but
we asked. It was an open question. We asked if there was a diagnosis before. I don't have the number. I could find it, but it's about at least 5 or 6, I think. But at least I have to check. But
okay, a quarter to a third, not so much.
So.
Okay, maybe some are not diagnosed. Maybe. Mm.
Okay, I'm sorry, but oh, sorry, there's another question, James, over there. It is the last question. I'm sorry. We need to go after.
Hi, I'm sorry to talk about boys, but there was mention of mosaicism in boys. I was wondering, has there been much study of that population? Like, is it even possible to detect in a boy whether they have mosaicism? And if so, would we expect them to behave more like a non-mosaic boy or a girl? And has there been a study in the rats, for example, of that population?
Well, I think it will occur in boys, and they are more difficult to diagnose, so there are probably more than we know. I know of one patient, a boy who was a mosaic, and yeah, well, you can see that because in the DNA analysis you will see. Normally in boys, there's only one copy of the gene, so you will only see one copy with a mutation. And in this case, they saw there was also a normal copy of the gene in the DNA analysis. So that's the way they found it. But you can miss it in a boy because, well, that's the earlier question. In a mosaic mutation in a boy, you can miss in the blood. If it's a very low mosaic, or maybe you can say something about the DNA. Low mosaics you can miss in the diagnosis. Yeah, true.
Well, thank you very much to all the speakers, and have a good lunch.